take a look at cleft palate as a cause of velopharyngeal insufficiency or inadequacy, not only with the cleft palate but after the cleft palate is repaired. Before we go into cleft palate repair, let's just orient ourselves to the anatomy and what a cleft palate looks like. So in a typical developed palate, we have complete closure of the roof of the mouth. We have the hard palate with the alveolar ridge right behind the teeth. If you touch the hard palate or hard portion of your palate where it's kind of bumpy, that's that alveolar ridge. That forms the primary palate. And then we have the secondary palate, which is the area just behind the alveolar ridge, all the way to the uvula. And again, we have the soft palate. So when we're talking about cleft lip, we're talking about the area up here, and sometimes it can extend into the alveolus or the gum line, or up into the nair on the portion of the front of the face. In cleft palate, the palatal cleft can occur anywhere along the extent of the palate. We can have an incomplete cleft where we have either the hard palate clefting, where we have an opening just in the front roof of the mouth. We can have an incomplete cleft of the secondary palate, where the front portion or the primary palate is fused together, but the secondary palate is open. We can also have something called a submucosal cleft, and that's where the mucosa of the tissue is fused together. So it looks like a normal and healthy palate when we look at it in the mouth, but if we go to the nasal side of the velum, we can see that there's a cleft in that tissue or that muscle on the other side. So overall, what we're going to really focus on is clefts that have openings, not submucosal clefts, which means that the mucosa has gone the direction of the bone, so the bone hasn't fused together, meaning that neither the mucosa or the muscle have also not fused together. So there are different variations of a cleft lip and palate. So the cleft lip, again, can have just a notch on the lip, or that's also known as the vermilion border. So that's the pink area of the lips. The lip can also extend into the nair, or part of the philtrum, which is just that little kind of cupid's bow forming on either side of the top lip. And it can be unilateral or bilateral, meaning that we have a cleft. In this illustration, for instance, is a unilateral left cleft lip, but it can happen on both sides. We can have a unilateral cleft lip and palate, where we have from the front we can see the cleft in the lip that extends into the nair this time, or in that area of the philtrum. And what we can't see just looking at this infant is the cleft palate, but if we look at the roof of the mouth, we have that complete cleft where the alveolar ridge is clefted and that secondary palate has clefted all the way to the back, giving us two sides in the opening of the palate. We have a bilateral cleft lip and palate, meaning that we have clefts on both sides of the nairs, and we also have a cleft palate that extends on both sides. These are really kind of those gaping holes we'll see in a little while. And then we have the isolated cleft palate. So from the front, just looking at the infant, there's no change in the face because there's no cleft of the lip. But if we look in the mouth, there is a cleft of the palate. So this is what it looks like on a real infant. This is a cleft lip, just extending in that vermilion border, a little bit up into the philtrum. We have a cleft lip and palate here on the right side of the infant, so unilateral cleft lip and palate. And this is a complete cleft lip and palate. So we have the opening here, and then just an isolated cleft palate. So here we have the alveolus, or the gums, are fused together, but the secondary palate is open. And then we have some other instances of children, so this is beyond infancy, what this can look like. This first one is a submucosal cleft, and that's where I said that the mucosa has fused together, but it's given us a bifid uvula here, and that's kind of our signature look of the submucosal cleft, and tells us that something is going on the nasal side of the uvula, even though everything looks normal when we're looking in the mouth. Here we have a soft palate cleft, or an incomplete cleft. So the bony part of the hard palate has fused together, but the soft palate is open. Again, we have an incomplete hard palate that might extend into the soft palate. You can't quite tell because the tongue is in the way. But we have fusion of the front portion of the palate with the secondary palate open, and here we have a complete hard palate opening. So what's that doing to the muscles? If we think about that levator veli palatini, that's our most important muscle for velar closure in that velopharyngeal port. So yes, the opening to the mouth is important, especially for articulation or shaping our speech sounds, which we'll talk about in our next module. But for this instance, when we're talking about sealing off the nasal and oral cavities, these children can't really do that because they have an opening in these muscles. So we have complete fusion in typical development, where we have the bony palate that's covered by the muscles in the mucosa. And this image highlights that levator veli palatini that's completely fused because the bones have fused. But if we have a, for instance, unilateral cleft palate, then we have incomplete fusion of the bony part of the maxilla, meaning that those muscles are going to follow that bony portion. So we have a portion of the levator veli here on this side, and we have a portion of the levator veli on this side. You can also see in this picture they highlight the tensor veli palatini, and so we have it here on this side, and it's going to be there again on this side, but they're not closed together to create that sling that's going to help lift and close the velum and provide that portion of the velopharyngeal closure. So this is before there's any repair. If the repair doesn't occur and these infants grow into children and shape their speech sounds, then we have muscles that are going the wrong direction. They don't even provide the sling to close the velopharyngeal port. And then if those muscles are fused together later on in development while they've already developed speech sounds, they really have to learn a new function because they're being brought into a different direction. So you can imagine in children with a cleft palate that they're really going to have resonance disorders primarily of hypernasality and nasal air emissions, because there's nothing to stop that resonance in the oral cavity. It's all going to come through the nose.